Good afternoon, everybody. Welcome to today's presentation, Pandemics, Endemics, and Epidemics, the risks of the non-innovative health systems. My name is Doug Moen. I'm the Director of Executive Education for the Johnson Sciama Graduate School of Public Policy, and I'll be your moderator for today's event. Johnson Sciama Graduate School of Public Policy, or JSGS, is a provincial center for advanced study and research in public policy administration. We are a partnership between the University of Regina and the University of Saskatchewan that was based on the spirit of cooperation and collaboration that defines our province. Since our inception in 2007, we have become one of Canada's leading public policy schools for educating graduate students and public servants interested in and devoted to advancing public value. At this time, I'd like to acknowledge that while today's event is taking place online, JSGS's physical home is located on Treaty 4 and Treaty 6 territories and the traditional homeland of the Métis. To help our event run smoothly, we would ask that all attendees stay muted and turn off their video. Thanks for doing that. And feel free to turn your videos back on during the Q&A. The format for today's event is as follows. Our speaker will present for 30 to 40 minutes. Following the presentation, we'll engage in a Q&A session. If you want to ask a question, please use the Zoom's chat function to send your question to me, to Doug Moen, and I will read out your question. Feel free to submit any questions at any time during today's event. If you have any logistical questions today, don't hesitate to send a message to Karen Jasper-LaForge via the chat function or to email her at jsgs.events@uregina.ca. And please note that, as with all our public lectures, this presentation is being recorded and will be available for viewing on the JSGS website at a later date. So, to introduce our guest speaker today, Dr. TARUN Katapally is a physician and patient-oriented research leader. After obtaining his clinical experience in India and the United Kingdom, Dr. Katapally went on to diversify his career towards health administration and population health, which culminated in a PhD in population health from the College of Medicine at the University of Saskatchewan. He established the Digital Epidemiology and Population Health Laboratory in 2017 to conceptualize virtual care and precision medicine applications. His team operationalizes cutting-edge applied research using the SMART platform, a big data toolkit that he's developed to intersect citizen science and social innovation for digital health solutions. His academic home is at JSGS. We're looking forward to an interesting and engaging discussion. I'm pleased to turn it over to TARUN Katapally to give his presentation. Over to you, TARUN.
Thanks, Doug. See, you could speak for 5 minutes, no problem at all. And if you do get disconnected, Doug's going to keep you entertained if that does happen. Welcome, everyone. Thanks for taking the time to join us in conversation today. I know this is a difficult time for everyone, so I really appreciate you taking the time today in between your Zoom meetings and your personal responsibilities. I will apologize in advance if I sound exhausted today. It's been a really tough year. The pandemic has affected my own family, my team members, and but the work is going on. So I do apologize if I do sound a bit exhausted. If there are people here who know me, they know that I'm usually quite excitable. So I'll try to be as excitable as possible. So as Doug said, I started my career as a physician and went on to get a PhD in population health science, a highly interdisciplinary field, with a particular focus in epidemiology. Recently, I've been awarded the Patient-Oriented Research Leader Award. Now, all these credentials, all this experience really informs my view of what's going on today and my view of health and health systems. I actually struggle thinking in silos, so I appreciate complexity. And I'll try to bring some of that complexity to today's talk while hopefully providing a window into the future. And that's why the talk has been named The Risks of Non-Innovative Health Systems. Now, those credentials are all good and fine in an academic setting, but I have the privilege of working with Indigenous partners across Canada, and they know me as TARUN from Saskatoon, even though I live in Regina. And as a settler scientist living on Treaty 4 territory, I'm very grateful for the opportunity to create societal solutions with Indigenous communities. I must thank all our funders from CHR, MITAX, Kipper, Sheriff, and Lung Association of Saskatchewan, without whom this work wouldn't be possible. So what I'm going to do today is ground our existing situation in the complex world that we live in, the digital world that we live in, and potentially come up with at least some good questions, if not solutions, and what can we do different going forward? What can we do different if we have to face the situation again, and what can we learn from this? Now, Doug told you that I started this lab in 2017, and we have grown a lot in the last year itself. I have to acknowledge my team who's all over the world. They're in 7 different time zones right now, working literally day and night, and without whom some of our work wouldn't go forward. Our key goal at the lab is to address societal issues. So for us, it's not just research impact, but also societal impact. And before COVID-19 hit us, one of our big focus areas was mental health. And we are using similar approaches in terms of rapid responses in dealing with COVID-19 as well. So having grounded you in what we do, let's talk about today's reality. You can't escape the fact that all we see is pandemics today. All we see is the word pandemic. But the existing epidemics and endemics have not gone away. So I don't want to bore you with definitions, but an epidemic is a disease in a large group of people in a geographic region, right? When you think of an epidemic, you think of probably Ebola. An endemic is a disease that is native to a particular region. Now, you can think of malaria in some regions of the world, but have these epidemics and endemics stopped because we have a pandemic? No. In fact, there is a clear overlap between pandemics, epidemics, and endemics. And you know what? When you think about epidemics and pandemics and endemics, sorry to repeat those words, don't just think about communicable diseases. Also think about non-communicable diseases. Think about the opioid addiction epidemic. I know that there's a lot of differences across psychologists and epidemiologists, whether mental health issues are an epidemic or an endemic. I'm not here to discuss the definitions. What I'm here to do is raise the issue of complexity. Don't just look at the pandemic, but also look at the existing epidemics and endemics and how they're playing out in the current situation. So I promise I'll stop with the definitions after this. So the word syndemic, or the term syndemic, is being used to describe or define COVID-19 by some epidemiologists. There's no consensus yet, but syndemic is basically synergistic epidemics that interact with each other. So, like I said, I'm not going to agree or disagree with this term. I'm going to bring to light the complexity that we are facing. We can't escape what's happening around the world. And when I was putting this talk together, I couldn't believe how many times I had to update the statistics and stats. So I had to stop somewhere. And this is where we were at last Saturday. And you can clearly see where the cases are higher. It kind of overlaps with current hotspots too, and you're hearing a lot of news coming out of India these days. So when I think about hotspots and total cases, and I think about waves, there's wave 1 in one country when there's a wave 2 in another country. It's a lot of noise. It's a lot of complex data to pass through. But there's one pattern that has emerged, which is the waves have been getting more and more severe in the last year. And look at where we were in April 2021 and look at where we are now. Every wave we get, and this is not just in one region, this is across all continents. So that's a worrisome factor. Where are we at with vaccinations, I'm afraid not doing so well. Apart from Israel, which has vaccinated a significant proportion of their population, the rest of the countries are not doing as well. So this is the current situation that we are facing. And this is something that we have to live with as we plan, as we move forward. Now, like I said, there is a lot of noise. There's an incredible amount of noise, even for an epidemiologist like me. There's talk about how the third wave is less severe. There's talk about how we need to learn from a country like India. How does an average individual pass through all this evidence? And this is not just noise that's changing every week. This is every hour. So what I would like you to think about is how can we influence positive behaviors while also addressing systemic change? That's what I want you to focus on, not just behavioral level interventions that, say, for example, help people to follow public health guidelines, but how do we change some systems to enable that, to build trust amongst our citizens and patients? So going back to the overlap, going back to our pandemics, epidemics, and endemics, there's a clear link between COVID-19 and non-communicable diseases. And these are not just news stories. There is actual empirical evidence now connecting non-communicable disease with COVID-19. And it's not just across the world, but it's in sub-Saharan Africa, Iran, and even Mexico. So this is the thing I struggle with a lot. We think that, that we use this saying, we use this term that, oh, this is the 21st century, this shouldn't be happening, but it is happening. Existing inequalities and inequities are perpetuating more COVID-19 mortality and morbidity. So that is the current situation. Could we have seen this coming? Yes, of course we could have seen this coming. And if you see the simple statistic, the pandemics and epidemics are only getting worse, but only getting worse in the last 100 years. And with our global supply chains, with our global travel, and how we used to live and we will live after this pandemic ends, it's much easier for pandemics such as, or epidemics such as COVID-19 to spread. The influenza epidemic that happened in 1918 reached countries like India months, years later. It takes days these days. So yes, we could have seen this coming. But our responses have been really reactive, from China to the United States to Europe, and even within Canada. I was stuck in Ontario, in the Greater Toronto area for almost 10 months, from last May to this March. And I saw this inconsistency in how each health region was tackling with COVID-19. Adjacent health authorities, adjacent jurisdictions were coming up with different policies. It is still truly disorganized. And not to mention governments like India now want to remove data from Twitter because they don't want to be criticized of their reactive responses. Unfortunately, that's where we are at right now. And I don't want to be all doom and gloom today, but I had to situate where we are at. So is there light at the end of the tunnel? We have variants coming from different countries that are apparently causing increased levels of COVID-19. Perfect example is India right now. We have vaccine hesitancy, not just amongst underprivileged or ethnic populations, but across the world. And millions apparently now are skipping their second doses. So this is another factor that we have to take into consideration. Vaccine hesitancy is being informed by misinformation. And that's rampant, as we all know. Vaccine rollout, it's not just a Canadian issue, but again, it's across the world. And 1 billion shots have been given, according to New York Times. But like I said, the waves are getting worse. And I don't want to be all doom and gloom. I just took a screenshot of this a few minutes before this talk. Apparently, there's one promising coronavirus vaccine that we don't talk about. It's the Novavax, and they have good supply chains, and the effectiveness of the vaccine is as good as Pfizer or Moderna. So I guess there's some good news, and we have to look at that seriously as we go forward as well. I don't want to divert too much, but investing in indigenous vaccine infrastructure might be the way to go as we move forward, investing in our own infrastructure. But like I said, I don't want to divert from our topic today. But what really, really worries me in terms of vaccines is the inequities, not just global inequities in vaccine distribution, but what's happening in this country right now. What's happening in Toronto right now really worries me, because even though the government of Ontario is not providing these data, individual agencies such as CBC News are doing their own analysis and showing that the vaccinations are being directed towards postal codes that are affluent. I pulled this from Twitter, and if you see the circle, that's where the hotspot is, and that overlaps with the BIPOC population of Toronto. And the pins are unfortunately where the vaccination are being given out at in a higher proportion. So this really, really disappoints me, because, again, in the 21st century, this is happening. So what is this causing? Of course, it's a strain on health systems. It's a burden on frontline workers. And again, this is empirical evidence. These are not just news stories. This burden, not just burden, but also risk to frontline workers. There's burden on critical care. There's burden on emergency care. There's burden on primary care, particularly when it comes to mental health. And there's burden on elective care. And you know what? When I think about our health systems, primary care and elective care are the core pillars. And if there's a burden on that, I don't know what to say. So what do? The answer is really not that innovative. We know what needs to be done. We need to reduce the burden. And we've been talking about this for decades, that we need to reduce the load of healthcare utilization by investing in upstream interventions. And I feel so redundant saying it. I don't know if that's going to happen, but let's say, what can we do different next time? Can we do anything different next time? Can we lock down hard like Australia and New Zealand? Do we look towards big data tracking and triaging like some countries have done, Israel, Taiwan, and South Korea? Or do we put all our eggs in one basket into vaccines in terms of boosters or new vaccines? All of these approaches by themselves are reactionary again, and I'm being cynical now. I guess I'm in a cynical mood today. We all have very short memories. And if you speak to historians about what happened in 1918, there's not a lot written about what happened after that influenza epidemic. People wanted to forget what happened, and we had the roaring 20s. And that's what economists are predicting now. We are going to have roaring 20s. And I hope this doesn't come true. I hope we have the roaring 20s, but I hope we don't forget. I hope we learn from this. So what is missing from our approach? We have the technology, we have advanced health systems, and we have human resources. And what can we learn? Can we learn anything at all? If not, the governments can, academics can, researchers, can individual jurisdictions, can health regions, what can we learn? The first term that comes to my mind is systems integration. This is not just about health system, is it? Or health systems. We are facing a very unique problem. It's a social problem. And we need to seriously think about integrating our systems across multiple jurisdictions. One way to do it is to share data and to link data. As simple as this sounds, this is probably the most difficult thing to do for us as epidemiologists. It's incredibly difficult because of our rigid structures. What is this going to do if we integrate systems and if we share data, if we link data in a better way? It's going to help us coordinate our activities. When I think about activities, I'm thinking about our policies and practices. So there is some standardization in how we respond across jurisdictions. But how can we do this across jurisdictions? Perhaps I don't have the answer for that today, but that's a question I would love to raise and talk about. But why do we want to do all this? It's not just for another pandemic or syndemic, but it's also for existing epidemics and endemics. I hope we learn from what's happening now in reacting or being proactive about our existing epidemics and endemics, and hopefully respond rapidly. And when I think about rapid responses, when I think about innovative responses, I think about how do we do this? The question I ask myself is, how do we go about doing this? I think this is my perspective coming out from my own team's research. Social innovation, digital health interventions, big data, and citizen science have a huge role to play. These are all, if I have to talk about each of these things, they would take an hour by themselves. So I would like to go over them without boring you. What is social innovation? Social innovation is the process of developing and deploying effective solutions to challenging and often systemic social and environmental issues in support of social progress. I was talking about how this problem is so different from anything that we've faced in our lifetimes. We might have the clinical medicine to respond to this pandemic and develop vaccines within a year's time. But it's not just about developing vaccines, right? It's about people taking vaccines. It's about whole societies. It's about a global society following a certain code, behaving in a certain fashion, wearing masks, abiding by public health guidelines. And that's where the social innovation comes into play. And when we live in a digital age, how can we go about doing social innovation if we don't think about digital health interventions? And thankfully, the World Health Organization has come up with its first guideline for digital health interventions. And when you think about digital health intervention, think about virtual care services. Think about addressing access gaps in real time. Think about alerting patients in real time. That's what I'm talking about when I'm thinking about digital health interventions. And the key here is building your network of citizens and patients. I'm going to use the word, yes, a social network of patients and citizens. But when we do this, what comes out of it? What comes out of it is big data. I think that's where our health systems can really innovate in thinking about how big data are being obtained, not just within health systems, but outside health systems as well. Of course, we have third-party services where we can get data. But what I would really like to emphasize is on direct population engagement, whether it's e-health platforms, m-health, mobile health platforms, or u-health platforms. I think this is where we need to invest in, and this is where we need to build the confidence amongst our patients and populations to be part of those platforms. You must be thinking, what is a u-health platform? It's ubiquitous health. You have Fitbits, that's an example, ubiquitous health platforms. So how do you get people or citizens or patients to get on these platforms? That's where citizen science comes into play. And this is where my lab is doing most of its work. From a research perspective, citizen science is a participatory approach where participants, termed as citizen scientists, actively engage in the research process, from data collection to knowledge translation. This can be applied to non-research situations too. So that's where health systems and health regions can come into play. It's not just for research. So citizen science can range from contribution, collaboration, and even co-creation, particularly when you think about remote indigenous communities. You must be thinking this is pretty close to patient-oriented research and community-based participatory research. Yes, it is. And that's where we have the advantage, right? We have already taken some steps in terms of our SPORE units, in terms of what we do from a community-based participatory approach. Citizen science is not a difficult leap. So this has really helped us in doing some of our work. And I think that's going to play a role in the innovation of health systems. And we can spend a lot of time talking about innovation of health systems, but I've distilled it down to these things. For me, innovation of health systems is decentralizing technology. What I mean by that is when we talk about these platforms, decentralize them and put these platforms in the hands of local decision makers and practitioners. And I'll give you an example towards the end of this talk of how we're going about doing that. Democratize policy and practice. This might sound idealistic, but if you want people to engage and believe what the scientific community is saying, I think we need to take this seriously in getting their voices out and into our policies and practices. Health systems have to realize that global health is local. If after this pandemic we don't realize that, I don't know, I'll forever be cynical. But we need to develop local solutions for global problems, right? It's not one size fits all. That's what we need to think about when you think about innovation. So how can we make this happen? Again, I'm going to be redundant and say share data. That's really important. Securely, anonymously share data. Cultivate direct communication with citizens and patients. This is so important for at least a significant proportion of the population to believe in one set of facts. And this is so important to do in addressing misinformation and disinformation. I'm not a health economist, but we need to incentivize citizens and patients for participation in these platforms. And I think that's one of the reasons why the Health Canada app failed. There was no incentives for citizens to participate. So if we don't do this, we'll have to deal with this again and again. As glad as I am that I don't have to see this, at least for now, but we have to deal with this again and again. But what is driving citizen science in the digital age? My research is not funded by any smartphone company or a big tech company. It's the reality that almost every one of us has a smartphone, and that enables us to reach individuals globally in real time. So it's as simple as that. That's why we are focusing so much on using these devices as tools of intervention, as tools of real-time access to large populations. So how are we doing this work? Last March, I was talking about how we can use our smart platform, not just for non-communicable diseases, but also communicable diseases. That's where our work with COVID-19 started. What is smart platform? It's a conceptual platform that allows us to ethically engage with large populations, the key term being ethical. It allows us to do integrated knowledge translation to our key stakeholders in near real time, and also allows us to develop behavioral as well as policy level interventions. It's as simple as that. And I call it a big data toolkit for digital health, precision medicine, and social innovation. So we are using the smart platform to address some of the issues that I've mentioned. A good example of how we are using smart platform is our CoAway platform. It's our rapid response, not just for COVID-19, but beyond COVID-19. When I came up with the CoAway idea, I started working with our Indigenous partners, our remote Indigenous, one remote Indigenous community who are our champion partners in this of Isla Lacrosse in developing it. It is a digital epidemiological platform. On the front end, we are building a virtual care application, which allows us to do precision prevention. Now you're thinking, why should people be on this platform? It provides them a service of precision prevention that allows them to make better decisions. At the back end, we have a digital decision-making dashboard that anonymizes data and provides the local decision makers with real-time jurisdictional level data to make decisions in near real time. It allows us to monitor, mitigate, and manage not just COVID-19, but also other issues in that jurisdiction, food insecurity and access to services. And this was developed in collaboration and partnership with the community of Isla Lacrosse. And this is what I was talking about, overlapping issues, right? We need to look at what the issues are in a particular jurisdiction, what non-communicable diseases are there that potentially interact with COVID-19. And we are going beyond systems integration here. We're using this platform for Indigenous self-governance and data sovereignty. What does that mean? The ethical piece is so important. The community owns the data. individuals own their data, and we take explicit informed consent. The next steps are what I call vertical and horizontal scale up. And this is where it would be so interesting to work with health system partners. When I think about vertical scale up, this can be scaled up across multiple communities, larger jurisdictions. But what is horizontal scale up? This can be used for other communicable and non-communicable diseases in the future. So we are building that digital infrastructure that could be replicated both vertically and horizontally. This is one visual of a feature called our virtual doctor feature, which assesses risk of getting COVID-19 in real time and provides people with that information so that they can make better decisions. So this constant real-time engagement, not just based on behavior, but also based on previous medical history. And we are using AI algorithms to do this. But the other aspect is citizens are able to report their own symptoms, their food availability, and access to services. And this was of importance to this community, and that's why we built it this way. So, when I think about risk of non-innovative health systems, I don't want to scare anyone, but this is a risk. I think big tech is going to play a bigger and bigger role if health system partners don't realize that we need to have a table when it comes to, we need to have a seat at this table of big data. Otherwise, there would be quasi-health systems. And we are already seeing this, We're already seeing that there are applications developed that are being commercialized where people are directly going to big tech for solutions, for upstream solutions, whether it's for mental health or other issues. If it helps to reduce the load on the current healthcare system, great. But what I worry about is the lack of or the reduction of relevancy of healthcare systems in the future. And it's not so difficult to imagine compared to where we were 20 years ago, where we are now. So I think I worry about that quite a bit. And that's why I feel like the benefits of innovation far outweigh the risks. And you must be having a lot of questions today in terms of opportunities, challenges, risks to citizens, benefits to citizens, and future directions. And I want you to think about these categories when you think about having a discussion with me today. I'd like to close by showing this image. I miss going to our lab. This is a college building of the University of Regina, where we've been given a fabulous lab by Johnson Trauma Graduate School of Public Policy and the University of Regina. So it's simple pleasures like that. I hope in another 6 months, if I do another talk like this, I'd be able to do it from our lab. And I'm so thankful for my whole team for, doing this work with me nonstop for a whole year. In closing, I want to also thank Karen, who's been very, very patient with me because she's been planning to do this talk for 4 months. It's been a tough 4 months because I've been teaching 2 courses. So thanks, Karen, for being patient. And Doug, you've always been a supporter of my research program and my lab. I really appreciate your support. And thanks everyone for joining me, and I look forward to our discussion.
Okay, thank you so much, Tarun. That was really, really interesting. We've got some questions coming in, and I'm going to put those questions to you in a moment. I just wonder, Tarun, if you would talk a little bit about how you would propose that provincial governments or health authorities take up these ideas and implement them. What's your take on that?
I think we have to start really small, Doug, with what we're doing with one community right now of around 1,500 people. And we have to figure out how to implement these platforms in a jurisdiction where you can integrate multiple services, learn from it, and scale it up in a stepwise fashion. So if we have successes in one jurisdiction, how can we replicate those successes? If we have setbacks, how can we learn from them? It's not a really, innovative answer, but it's as simple as that. If you take Saskatchewan, I think we are, we have a perfect province to do this. Our population is not large. We have one health authority. Most of our population is segregated in 2 large cities, and we have several smaller cities and towns as well. In my view, in an ideal situation, we have to start small and keep building up and see where we land in about 5 years. And we have to have that long-term vision.
Okay, so I got a question from Anastasia Tarun. Right now we observe the rapid increase in cases in spite of strict restrictions across the country. And many scientists are still unsure of the vaccine efficacy for the new arising variants, which can have an impact on vaccine hesitancy in terms of their effectiveness. Would you say that right now we are in a race against virus mutations, and can you suggest a potential solution to mitigate this rapid spread and people's willingness and ability to cope with this pandemic?
Oh, boy. Like I said in one of those slides, it's not just vaccines, is it? We also have to be proactive with our public health measures. Very often, I completely sympathize with everyone, especially who's outside the medical field. It's exhausting. These lockdowns are exhausting. But if you look at the evidence from New Zealand and Australia, you can see that they're working, right? And look at what's happening in New Zealand and Australia. They're not vaccinating their population as fast as countries like States, UK, or even Canada. But why are they doing so well? You have to think about that. So vaccines are definitely the key, but they're not the silver bullet, as you can tell from what's happening in India, which is a vaccine powerhouse, which has vaccinated about 100 million people. I do think it's a race against time. In February, we were saying there's light at the end of the tunnel, right? And look at where we are. It's close. It's almost May, but we are seeing cases go up in Saskatchewan, Nova Scotia, Ontario. From what I've read and what I've heard, it's a lot to take in every day. We are getting a huge batch of Pfizer vaccines this month or for 2 months. I hate predicting things. And every time some of my family members or friends ask me, I've heard this epidemiologist say something on TV. I said, my honest answer is, we really don't know. But if we are going to mobilize ourselves in the next 2 months and get these vaccines into people, I think we will be in a better situation. But it's not just vaccines. We have to be proactive with our public health measures as well. And we need to be clear about communication. And that's one of the things that is currently lacking, is a direct line between us, if I say us as researchers or health system partners, and our citizens and patients.
So Farva's got a question here, Tarun. How come in such an advanced country we are unable to coordinate our data? Is it some political reluctance to share the facts that are going on in their province? Is it due to financial issues that we are not able to connect among different territories?
How much time do we have? Oh boy. Our systems are set up in silos. 13 jurisdictions, right? That's how we provide healthcare, right? We inherently are rigid in sharing data across provinces. That's one thing. The system is set up in such a way. And I do think that we have to, well, of course, we have to protect data. Privacy is really, really important. But I feel like there is lack of innovation when it comes to that. The first thing that I've noticed, and I know how hard everyone's working in the health system, and I'm not here to criticize anyone for all the great work that they're doing, but my experience has been liability is a big scare. And when it comes to data sharing, everything slows down, or when our partners think about potential risks. I do think that we have the technology. I don't know if we have really, really good data across the board. I'm not talking about just health data, but I'm talking about data across all sectors. 2019, Globe and Mail did an article called Our Data Gaps. And I wrote a piece after that in Conversation Canada of how citizen science can address our data gaps. We have data gaps across sectors. We have good data within health systems. It's difficult to link data within health systems, let alone across jurisdictions, let alone across sectors. So we have a lot of work to do. And my approach to this in a small scale, at my pay grade level, is start small and try to work with few jurisdictions in systems integration and show that this actually works. But I hope that wasn't a non-answer, but huge challenges.
So, Tarun, a question from Hajan, another data-related question. How can we motivate both the healthcare providers and patients to share data? And who really owns that health data?
Well, my view is that if you want to motivate patients, they should own their data. I think if that's the best way to motivate someone to provide data. We've engaged more than 1,000 youth citizen scientists in Saskatchewan over the past 3 years for different projects, for different initiatives. Because of the way we do the engagement, where we explicitly say that they own the data, they're able to delete their data whenever they want, they're able to pause their data, they can manage their data. We've had one request for data deletion. I take pride in that. And I'm not speaking from this is not just my opinion, this is just based on evidence. And sometimes I feel like health systems need to look at other systems in how people's behaviors impact what motivates them. I don't want to be facetious here, but we all love Costco. You know why people love Costco? There are many reasons. You can take any product back anytime you want. And Costco has a huge following for that. I don't see that kind of marketing behavior or marketing strategy in health systems. You see what I'm saying here? It's not just about health data, is it? It's about, let's look at what other sectors are doing in motivating people to provide data. Why are we downloading app after app every day when we know that big tech or Facebook is mining our data? We need to really think about that. And I think therein lies the answer in how to motivate individuals. I don't know how to motivate healthcare organizations to give data, and I work with citizens and patients, but that's my answer.
So, Tarun, while we're sort of traveling in this area, you made a passing mention of COVID alert, the federal COVID alert system and its failure. So, any comments on that? In terms of what to make of that particular effort, and what the significance of that has been. Like, what does it tell you about what needs to be accomplished here?
First of all, it's so disappointing that we have the technology to do this, and the intent was there. I gave the federal government the benefit of doubt that the intent was right, but the failure highlights what I was talking about before, wasn't I? Because of our siloed system. It was 2 or 3 provinces who adopted it early. I think it was Newfoundland, and then it was Saskatchewan. But it largely failed across different provinces. That's at a provincial level. But there are 2 key points here. I've used the app for a while. I've deleted it. The reason I deleted it was it was not providing me a really good service. It wasn't telling me how to behave in this confusing world. It wasn't telling me that my risk went up because I went to a grocery store 3 times this week rather than 1 time in 2 weeks. It wasn't telling me what my safe spaces were. that was a big issue for me. You know, what kind of service is this providing me? Oh yes, there was one alert in terms of if you can come in contact with someone, and the Bluetooth technology was being used. But I would love to see the validation of that. I don't think that was truly successful. So that's the service aspect is huge. It wasn't really providing service to individuals, let alone individuals, not even to me. And I'm very sympathetic to this technology. The other thing was what is the incentive for citizens to use this? And I've talked about this before. I'm not a health economist, but we have come up with the economic stimulus has been incredible, right? The way the federal government has stepped up to help people. And I don't want to go in the direction, I'm not a health economist, but how about a simple tax credit for this? Why can't we give tax credits for people to use the Health Canada app? I'm raising a question there. Oh, forget that. How about a free dental visit? How about a free drug that isn't free? I don't know. We don't have pharmacare. I can come up with 1,000 things right now. But again, like I said, it's disappointing. It's disappointing that we have this incredible technology and we have come up with that. Yeah.
Okay, thank you. So this, I think there's a connection here to this discussion. A question, how much emphasis do you believe government should be placing on preventive strategies and in parentheses, lifestyle-based solutions?
It's a very broad question. I'd like to think about prevention at a population level. My worry about talking about lifestyle-based is that people would be blamed for their behaviors. And I think you really have to think about the hotspots right now. Where are the hotspots? High density areas. Who are getting infected? Frontline workers, people who don't have a choice, who have to go into work every day. They do not have a choice of working from home, like several of you and me. When you think about preventive measures, those have to come from beyond the health system, right? There's this whole argument, there's this whole thing in Ontario that's going on about paid sick days. That's a preventive solution for me. That's an upstream solution for me. I think I'm not a psychologist here, I'm not a behavioral specialist, but there's extrinsic motivations and intrinsic motivations. And people who are intrinsically motivated will always do better. People who have higher education, take for example, physical activity. You don't have to tell me to be physically active. I have lots of intrinsic motivation for that. And intrinsic motivation actually works. Extrinsic motivations fail to work after a certain period. So what I'm trying to get at is, I think this change has to be, yes, prevention at a systemic level across systems. But if we are talking about individuals, because we have the technology, the prevention should be precision prevention. If you're getting someone to use a digital tool, you can make it precision prevention. What I mean by that is we have the technology, we have the AI, artificial intelligence, and we have machine learning algorithms that can accurately predict a lot of things in terms of your behavior. You can use that to enhance or improve or facilitate positive behaviors. That's where I would focus on, rather than old-fashioned health promotion behaviors. Yeah, the term that comes to my mind, I don't know. I feel old, Doug. Doug, I feel really old saying this. Say no to drugs from Nancy Reagan, right? Yeah, let's not do that.
Okay, I have a question from Sarah, who appreciated the presentation and was excited about the app that you referred to, the GoAway app. How is the data reported by individuals used currently? And she sees the potential for incorporating the data into population modeling, for example, agent-based modeling, and for validating these models in small populations. Any comment on that?
Oh, absolutely, Sarah. I think there's a huge role for the big data that we are collecting or we are sensing, or that could be used for these modeling approaches. Absolutely. So we are on the same page there. But what we're trying to do is, before we even model, we are trying to use AI algorithms and machine learning to improve what I call that precision prevention and provide real-time data analytics to key decision makers in that community. So it's a bit of both. We don't want to wait till we model something. What we're trying to do is in near real time. I think there are two things that are going to be critical in the success of this, shall I say, experiment. We've already made a decision that this is not just for COVID-19. So that's why we are building it in such a way that it could be used for other communicable and non-communicable diseases in the future. So how can we embed that digital infrastructure into a jurisdiction's functioning? There is a good model. Now, there is a good model that could be replicated in smaller jurisdictions, like say up in Yukon. So I hope I've given Sarah some indication of where this is headed.
So great segue. Greg is, I believe, from Yukon and asked this question: how will the rollout of COA work in regions of the Indigenous North where there's poor internet service and residents just don't have the funds to own and operate a cell phone in a high-cost region? What's your thoughts on that?
Yeah, great question, Greg. I'd like to think I coined a term called internet inequity. I put it in one of my papers. When I think about internet inequity, it is disproportionate access to internet based on geographic region, socioeconomic status, so on and so forth. We do require systems level change for this to happen. And I think the feds in the past couple of budgets, including this one, have pledged more funding for internet access in rural and remote areas. So hopefully that's going to make a difference. I know Starlink, if I'm being correct, is coming up with some pilots across Canada, and I'm really hopeful that would make a difference. But from a more downstream perspective, where we are at, I would say right in the middle, what we try to do when we work with a community is to ensure that most of the population has access to devices as well as data plans. We've been lucky. The federal government has been extremely generous. The Saskatchewan budget for these data plans over the next 3 years, at least in one community that we are working with. I know that is not a final solution right there, but we are. What I'm trying to say is, when we are trying to implement this, we make sure that our citizens and patients have equitable access. And yes, that is still a barrier. It is unethical to go into a community where you can just implement this amongst 25% of the population, when 75% of the population, which doesn't have cell phones or doesn't have smartphones or data plans, they are the ones that need the services. So it's something that we have to continue to work with, but I would say we've been reactive to the reactionary forces out there, and we budgeted in the short term. So that's as honest an answer I can give you, Greg.
So TARUN, just so you know, Greg was Greg Finnegan in Yukon, the former ex-chief statistician, and just put his offer out to help in Yukon, so you know.
I know, Greg.
There you go. Well, you can connect then. From Kwaku, given that most people in Canada have family doctors who explain the benefits of getting vaccinated, what could have or can be done better in mitigating the fears of those who have been misinformed on vaccinations, or maybe hesitant because they don't really trust health systems?
Oh man, I'm gonna sound so redundant now. I feel like I'm gonna repeat my whole presentation. Isn't it surprising that people don't trust health systems, but they, in some ways, trust big tech or don't care about where their data is going? I find it flabbergasting. I'm like, I know that, Google Maps knows where my home is. I still use Google Maps. I don't care. What I'm trying to say, what I'm trying to get at, again, trying not to be facetious, we have to build a direct line or cultivate a direct line to our patients and citizens. Now, who do patients and citizens trust? That was a very good question. They trust their own decision maker, they trust their own practitioner. And that's what I call decentralizing technology. If we put these platforms in the hands of practitioners and decision makers, and they are able to engage with their patients or their citizens in real time, I think we perhaps would have a chance. We would have half a chance in at least 70 to 80% of the population believing in a common set of facts. And we are close to states. That doesn't help. It's where we are at in terms of belief in science. We're not as bad as states, I suppose, but we're still better. We can fight with those forces, but we also can't blame people for being ignorant. That language really doesn't help, especially if you think that ignorant person's decisions are potentially going to kill other people. The solution here is to understand this process, understand that we live in a digital world, understand that every 5 seconds someone's looking at their smartphone, and build or cultivate a direct line and build that trust with the citizens and patients. And they will not trust potentially a provincial decision maker or a federal decision maker, but they might trust their local decision maker or their own doctor. So that's where we need to decentralize some of these platforms.
Okay, Tarun, a couple of questions from Heather. Can you explain why provincial public health powers have not been used more extensively to improve pandemic responses? First question. And number two, are there other ways to move towards more evidence-based, less political responses?
I can't answer the first question. I don't know. Honestly, I don't know. And I certainly, and like I said, when I started this presentation, I'm exhausted just like everyone else. And as Doug knows, I'm super excitable, but I feel more and more cynical these days. So I really don't have an answer for your first question. I'm as disappointed or as confused as everyone is. Doug, I was thinking about the first question. Could you repeat the second question, Doug?
Sure. Well, I think your frustration is probably shared by a lot of people. So the second part of the question, are there other ways to move towards more evidence-based, less political responses? So, part of what you're doing here is all about improving, the quality of evidence on the ground. And so, any thoughts on that? Finding more evidence-based ways to address some of these issues?
Yeah. Like I said, as the cliche goes, all politics is local, right? And I'm going to repeat myself. We really need to figure out how to decentralize some of these technologies where we connect. Again, I'll repeat myself. Connect local decision makers, local practitioners directly with their patients and citizens. And I think I'm going to speculate here. When I talk about citizen science, I'm not talking about citizen science that happens in ecological sciences where citizens randomly collect data and analyze data. That's not what I'm talking about. I'm talking about citizen science in public health, where we amplify the voices of citizens. And when you amplify the voices of citizens, and if the decision makers think that these data are coming from citizens and citizens are voters, I think it's going to make a difference. And we need to figure out a way how to amplify those voices at a local level and build those decentralized platforms. And it would be impossible for us to manage misinformation and disinformation if we don't take local geographic, cultural, historical aspects into context. And that's why one size doesn't fit all. There are some good examples of how to address misinformation. Finland is doing some really good work with the education system. You need to look into that. There are good examples out there. We need to look towards countries that are doing better in this area. We need to look towards countries that are more cohesive when it comes to understanding facts. What are they doing different? It's going back to systems integration. It's got to start with education as well, right? It's got to start with building these curricula to address misinformation and disinformation at a grade school level. Perhaps it's too late for people like you and me, Doug, but I think I think we need to focus on the next generation, right? So in my own cynical way, I'm a bit hopeful that if we do that, we'll have a better chance.
So Tarun, just building on that, when you look at, is there a country or a subnational out there that you look to who you think is really doing leading edge work in this area, that's making some progress?
The easy answer, and some people might think this is a Bernie answer, is Scandinavia. But it's a low-hanging fruit to pick, right? But some of the countries have done really well. Israel has done some good things, but what Israel has done with big data, it won't fly in Canada. Never. Taiwan has done some really good stuff in how they've triaged patients or citizens. South Korea has done really good work. Vietnam has done really good work. And of course, I've mentioned Australia and New Zealand as well. So there are jurisdictions out there from whom we can learn. Come on, look at Canada itself. Why did Atlantic Canada do better? Right? We don't have to look that far.
So that's, I mean, a lot of those jurisdictions have done pretty well when it comes to the management of COVID, but in terms of citizen science, in terms of, smartphone technology and like being leading edge in that area, is there a particular place that you think about as being ahead of the curve on citizen science?
Perhaps not on citizen science. Citizen science is still very popular in ecological sciences and environmental sciences. And there's some great successes there. Climate change is one area, and you have to link climate change with health. And our lab is doing that work now, connecting climate change with mental health and food security. But apart from that, I don't think citizen science is big anywhere in the world right now. Some units are doing it. We are one of the few units in the world who are actually championing this work in public health. However, if you just think about data and the utilization of big data, I would say from my recent reading, Israel and Taiwan have done things that are probably never possible in Canada. Yeah.
Okay, so you had mentioned, Tarun, the work that's the potential for work going on in communities, or the connection with community, and you've been doing some. You had mentioned in your presentation the work you were doing in Isle Across. Do you want to just talk a little bit about, what the potential is of that research that you're doing in one particular community?
I'd like to think there is huge potential for the work that we're doing in Isle Across. I was talking to you and Karen the other day. One of my pet peeves is, and you're forgiven in the audience if you've used the word app. When someone comes up to me and says, "Are you building an app?" and I smile and I say, "No, we're not building an app. We're building a platform. We're building digital infrastructure." So the potential in Isle Across is that we are building digital infrastructure that can address issues beyond COVID-19, and some of the things that we're addressing are mental health among youth, and that's real-time risk assessment, not just assessment, or prevention of anxiety and depression. We are working towards addressing food security and climate change, and not in silos. So what I'm saying is, you could build one digital platform for one community, and it's possible at least in smaller communities, that can address the imminent issues in that community. You can take the same approach. That's what I mean by local solutions to global problems. Climate change is a global problem, mental health is a global problem, food security is a global problem, COVID-19 is a global problem. But we are taking a local approach, a culturally responsive approach in addressing those issues, working closely with partners in all across. And I see incredible potential in going forward in the next 3 or 4 years.
And it would be fair to say that you've had pretty solid assistance from the political leadership in that community.
Absolutely. They are truly visionary. Yeah.
Okay, from Ramona, can you speak about the importance of digital innovation evaluation? How can we systemically evaluate the impact of innovation or lack thereof? This is a particular challenge in preventive health.
Yeah, great question, Ramona. I think a good, the last 3 grants we got for digital innovation were all about evaluation of digital infrastructure. So we have to build evaluation frameworks in conducting these projects. What I mean by that is when we implement these projects, at least from my perspective, we have to develop indicators of success at the get-go, and we have to do process evaluations and hopefully an impact evaluation at the end. I highly value the field of evaluation. That's why we have some of the best evaluation experts in our team who are enabling us to evaluate not just our development, not just implementation, but also potential knowledge translation. What I mean by that is how can we refine the platforms that we are building in potentially in near real time. We can only do that if we build evaluation frameworks and approaches right at the get-go. So yeah, we're doing everything we can to do that.
Okay, for Chris, it doesn't seem that direct communication with citizens has helped with the sensitization of the impact of this virus in the province. The virus, including variants, seems to be increasing. You mentioned incentives when discussing local solutions for global problems. How can that be implemented in the province? And is there data to show that such can help with sensitization and reduction of spread? What incentives, what were incentives part of the strategies adopted in places like New Zealand and Korea?
Well, to start with, I don't think there was a direct connection. I don't think anyone's cultivated a direct connection with citizens and patients. And what I mean by that is doing press conferences every other day is not direct connection. And I'm not criticizing anyone for that. That is not direct connection. What I mean by the direct connection is connecting directly to a potential digital social network that provides people with real-time alerts, that is sophisticated, not even sophisticated, that is flexible enough to respond to the changes in that particular community. I'll give you an example here. I was stuck in Ontario, like I said, for 10 months, and we were in lockdown for almost 10 months. And when I talked to my colleagues and my friends in Regina and Saskatoon, they were saying, and I wasn't here, it was just anecdotal, that restaurants were open, things were almost as normal as possible. A lot of people were not wearing masks. I'm not agreeing or disagreeing with that anecdotal evidence. From my perspective, I'm thinking, hey, don't you see what's happening in the rest of the world? Don't you listen to what's happening to the rest of the world? The reason, according to me, is, it's not my problem. This is happening somewhere else. This is an Ontario problem, and we are fine here. Now, I'm not blaming anyone for believing or thinking like that. What I'm trying to emphasize again is, if you want to cultivate a direct connection to citizens or patients, I'm really talking about decentralizing to a local jurisdictional level, not at a provincial level, to a level where our family doctors have a direct connection with that. And that might sound very futuristic, but that's what I'm talking about. And if we at least achieve that to some small extent, I think we would have a better chance. I would listen better if It's as simple. I practice medicine, and I know that if my physician calls me and has a direct conversation with me and I see my physician's name, I put value on that. Why would I put value on general messaging, which is really, one size fits all, right? So I think we need to do a lot more to cultivate that. So I don't think we've done that, not in the least.
Okay, so we have a question from Haley here. A potential barrier to integrating data systems is the cost. So who will pay for it, TARUN? Do you have any suggestions on who could take the leadership role to get things started?
I don't want to get all philosophical here, but cost is used as a hindrance for anything progressive. And I'm not speaking politically progressive here. I'm talking about any innovation. Cost is the first thing that's talked about. Who's paying for it? And I have to give a personal answer here. And you look at the federal budgets and everything, or the provincial budgets, we are in deficits and we are going to be running deficits. I do think that we have to accept that, I'll repeat it again, we are living in a digital world, and this has to become part of our operating budgets, a part of our regular functioning. That's very, very important. And I think smaller, people like me might work at a level where we are working with one jurisdiction and we might show success. It might take 5 years. But if we have to really scale this up, honestly, the cost ultimately has to be absorbed by our provincial and federal governments. That is the way to go. And if we don't do that, and I said that's the risk of non-innovative health systems, I think big tech will have a bigger role to play in how we move forward in getting health and healthcare. So we have a choice to make, and I think we have to make that sooner than later. Whole industries have been transformed by big tech, taxi industry, hotel industry, you name it. What makes you think that the healthcare industry is immune to that, or the health industry is immune to that? If you see how Apple has invested in the last 10 years, it's a clear indication of where this is going. It's the writing is on the wall. So I'm not sure if I was able to answer Haley's question, but it's something that we have to bite the bullet.
So we have a question here, TARUN, from Alistair, and he says, Western governments have a habit of atomizing people and problems into manageable chunks, distinct organizations with separate mandates and scorecards. What have you learned from Indigenous communities that has informed the way you think about our path forward? You have been very focused on sort of Indigenous health and opportunities in the Indigenous community. So what's going on there that informs the way you think?
Great question, Alistair. The approaches that we're taking in addressing issues in partnerships with Indigenous communities are highly applicable to other jurisdictions and communities as well. The way we conduct consultation, the way we engage with our partners, the way we think holistically and not just about physical health and mental health and put everything in silos, I think there's a lot to learn from it. And I certainly struggle with these silos, right? I struggle with these silos when we break them off and we look at, this is my area and this is what I want to look at. I'm not proposing that we have to change the complete paradigm. What I'm trying to say is we have to look at, if we have to look at systems level change, then let's not just look at one health outcome at a time. We have our provincial and federal priorities. Yes, we've invested a lot of money in mental health, which is a great thing. We need to do that. But let's not just focus on one thing. Let's focus on other aspects as well while we are doing work in this area. I don't know if I'm rambling here, but for example, when we do mental health work in partnership with Indigenous communities, we embed land-based active living that's culturally appropriate in improving mental health of Indigenous youth. So that's a holistic way of doing things. Can we take that approach more often? Yes, I think we can do that. Perhaps it's preaching to the choir here, Alistair, but we have a lot to learn from Indigenous communities.
Okay, so we have a question here, and I'll just say to the assembled that this is the last question that I've got. So if you've got any other questions, we have room for another handful of questions if you've got them. So from James, he says directly observed information using digital photography is very interesting. Digital cameras are everywhere. In the sports world, there are multiple cameras, slow motion replay, and commentators who provide different perspectives. My daughter uses photographs and video data on digital platforms that I don't have any literacy using. I'm curious how you see digital technology challenging people to be more accountable.
Yeah, great question. When I think about digital platforms, I'm not just talking about, and I didn't, because the focus of today's topic was the complexity of this pandemic. I didn't talk about hybrid platforms. So what I mean by hybrid platforms is it's not just citizen scientists, but there are so many sensors out in the world that can give us big data, which we can analyze in real time to arrive at solutions. Whether it's understanding what's happening to permafrost in the north, if we can reduce the risk of fires or reduce the risk of flooding. I think the great thing is the technology is there. The unfortunate thing is that we humans are not even close to leveraging the technology that we have. We haven't figured out the ethical protocols and the ethical implications. That's where the work needs to be done. It doesn't have to be magnanimous. It doesn't have to be incredibly ambitious, but we need careful, thoughtful, complex thinking and using existing technology and addressing the issues at hand. And what better area to go into than climate change and health if we are to leverage these hybrid platforms? Yeah.
So I think this will be probably the last question, Tarun. It builds on this last question that you've just spoken to. Where do you see the field of digital health headed in the next 10 years?
At the moment, I'm not very hopeful if we don't change some things. I feel like when I say I'm not hopeful, that digital health is going to grow. When I say I'm not hopeful that our systems will adapt as fast as they should adapt. I do think that we need some sort of a national direction, some sort of a national strategy in using digital innovation. I do think there's going to be a lot more commercialization. I do think big tech is going to be playing bigger and bigger role. They are starting with active living, physical activity these days in terms of how they're using the technology for health, but that's going to go into other areas. That's going to go into areas such as climate change, cardiology, which is already happening, communicable diseases. And if you look at who controls most of the data, that's what worries me. So that's my cynical view of what might happen. But if I have to end on a positive note, I do think that there are chances if we actually change the paradigm of how we look at data. If we put value on our own data, if we don't give up data so easily to big tech, I sometimes wonder why we are paying so much for our data plans when our data is being used for all sorts of commercialization processes, right? We need to change the way we look at each individual's data and put a price on it. And I'll go back to talking about how we need to incentivize people to participate in these platforms. So I'm hopeful that we will do that, but so far I haven't seen the evidence of that.
Thanks, Tarun. Really appreciate your presentation today and your questions on behalf of the group today. Just thank you so much for taking this on. And on behalf of Johnson Shama, I really want to thank everybody for participating in this discussion. Really interesting discussion. You know, there's a reason you're exhausted, Tarun, because I mean, you've been working in this area, but we're all kind of exhausted by it. And it's really important to just take a little time and talk things through and talk about how the future might look. So thank you so much for helping us with this. I just let everybody know that Karen's having a busy week. There's a number of things going on in Johnson Shama, which may be of interest. Tomorrow, JSGS is pleased to be launching its new Equity, Diversity, and Inclusion discussion series with guest speaker Selena Caesar-Chaban, a business consultant, coach, national speaker, and author of Can You Hear Me Now, former member of parliament, at the event entitled Rethinking Equity. So there'll be a number of speakers in the EDI discussion series, and this is the first one. Also on Thursday this week, so Selena is tomorrow. On Thursday, we'll be discussing COVID vaccines and how they get from the production lines to the people. It's moderated by Dan Florzone from the school. We'll have an expert panel joining us made up of Brigadier General Krista Brody, the Commander Military Personnel Generation Group, Dr. Volker Gertz, the Director and CEO of Vito Intervac, and Colonel Scott Malcolm, CDMD, Deputy Surgeon General, the Canadian Forces Health Services Group Headquarters. The event details and registration information are on JSGS's online events calendar. So if we could just give our speaker a virtual round of applause. Again, thanks so much, Tarun. Great to have you with us today and talking about a really important subject. Thanks so much.
Thanks, Doug. And everyone, please stay safe. This thing is so real. This is affecting everyone. I hope you stay safe. I hope you get this is one thing I'll say, get the vaccine. Any vaccine you can get it.